So it's my very great pleasure and honour to introduce my dear friend and colleague, Professor George Pantalos. George has been a cardiovascular explorer for over 48 years. Much of that effort has included the development of surgical devices and procedures to make research projects possible. He's been a professor of cardiovascular and thoracic surgery and biomedical engineering at the University of Louisville, in partnership with Jewish Hospital and Norton Children's Hospital since July 2000, after holding similar appointments at the University of Utah for 17 years. His efforts to investigate cardiovascular function have focused on understanding and treating heart failure with mechanical devices, including artificial hearts, ventricular assist devices, and cardiopulmonary support systems, which he has helped develop, test, and implement clinically in patients with 2 legs and with 4 legs, with big hearts and little hearts. George has also collaborated with NASA for many years, helping to understand cardiovascular adaptation to the weightlessness of spaceflight and the return to Earth. George has flown 53 NASA-sponsored research missions on parabolic flight aircraft and led the development of a cardiovascular diastolic function experiment that included an instrumented artificial heart beating on a circulation stimulator that flew twice on the Space Shuttle Discovery. Other reduced gravity research projects have included delivery of effective chest compressions for CPR in 0G, organ perfusion in 0G, and the development of surgical capabilities for exploration space missions. The surgical fluid management system being developed by his project team has just completed a successful suborbital spaceflight evaluation on the Virgin Galactic Spaceship 2. Outside of his research, development, and public policy efforts, George enjoys traveling with his family, playing baseball and biking, being a weekend percussionist, volunteering with the American Red Cross, and making baklava. With his fellow students, staff, faculty, and patients, his motto has always been, share the adventure. So thank you very much indeed, George, for coming along today, and over to you.
Thanks very much for that generous and kind introduction, Rowena. I'm sorry, all I could do today would be share a picture of baklava, but I figured that would be a nasty teaser. So we'll just have to wait until I visit Australia, and maybe I could bring a fresh batch to share with everybody. But it's very nice to be with you. Good morning to all of you. I would, since this is a cardiovascular segment of the course, I'd like to share with you some of the different things I've done with my cardiovascular research related to spaceflight. This is by no means intended to be a comprehensive review of the cardiovascular research that's gone in on spaceflight, but at least a snippet of some of the things that I've done to help everyone understand what changes take place in the cardiovascular system during spaceflight and with return to Earth. By way of disclaimer, my training is both as an engineer and as a human physiologist. So you will notice a decided direction in my research that may not be as familiar to you. Like I said, I've been a cardiovascular explorer, and sometimes gravity is involved and sometimes it isn't. By way of a brief introduction to supplement what Rowena just provided for us, I started out as a bona fide rocket nerd. I don't know if any of you had the joy of designing, building, and flying model rockets, but I did, and I still do. And it was not only fun, it was a great way for me to get an introduction to engineering and aerospace engineering, which has guided the approach that I take to my research. But then when I was in high school, I had a curious event where I realized that a lot of challenges in medicine involve engineering solutions, whether it's understanding the physical or the chemical or the biofluid mechanics aspect of normal and disease function, or whether it's developing a new medical device, whether it be a diagnostic or surgical tool to help get the job done. Fortunately for me, I did all my training at Ohio State, where you can walk easily from the engineering school to the veterinary school to the medical school. And one of the professors in veterinary medicine was willing to teach you whatever you were willing to work at. And so he and his faculty taught me basic surgical skills. And that way I could conduct all my own surgeries for the animal research that I was conducting. And that helped me get tuned into what life is like for a surgeon, even though I'm not a clinical surgeon. And here you can see me operating, implanting pressure sensors and sampling catheters in and around the heart of the test animal, and then it recovered. And about 7 days later, it walked over to my lab, and we hooked up the sensors and recorded lots of good blood pressures and blood flow data. And then eventually, I was fortunate to be able to combine both interests with NASA-sponsored research. I had posed a hypothesis related to the role that gravity plays in cardiac diastolic function. And I will discuss that a little bit later here in the presentation. Now, as far as other disclosures go, I have no financial or other entanglements with any of the information present. But if I have to be fully transparent with you, this is my 3rd grade report card. If you open it up, the grades on the left are the stuff nerds are made from, so that's pretty boring. But if you look at the other side, my personal development and social growth was totally devoid, except for one category I excelled at, which if you look closely, you can see it says talks too much. And unfortunately, my parents would say I'm a much better public speaker now than I was in the 3rd grade, but unfortunately for you, I talk too much. So I hope you have a good cup of coffee and are expecting to spend a little time tonight. Hopefully not too much though, because I know we got other things to do. Oh, heck, you've got the rest of the day ahead of you. Just to visit the anatomy a little bit, I'm sure that you've seen the anatomy in lots of different ways, but this is one view. This is a anterior posterior MRI plane of an average adult human, 70 kilogram male, happens to be myself. I'm a pretty average guy. At least I'd like to think so. And here you can see my aortic valve, my left ventricle, right ventricle, aortic arch, pulmonary artery. Heart is snuggled very snugly in between my left lung and my right lung. And then of course there's the muscular and skeletal chest cage around it. Here's my diaphragm, and then the abdominal contents. This may be all very obvious to you, but the mechanical and the fluidic coupling between the different anatomic structures will have some influence on some of the cardiovascular research that I'm going to point out to you. But just to give you an example, some of the other imaging that I see, this is a AP chest film from a patient that I participated in their care. Patient that was in end-stage heart disease, received a left ventricular assist device, which you can see implanted in the abdomen after the implanted pacemaker defibrillator was not sufficient. And this supported the patient for many, many months until a suitable heart for transplant came along. This was one of my younger patients. This was still when I was out in Salt Lake City. And he was getting ready to be discharged home, so we thought it would be a good idea if the local EMS staff were aware that if they showed up at this house and this guy said he had an artificial heart, that he wasn't kidding. This is another AP chest film from one of the patients with a total artificial heart, which you can see there in the cardiac sac where the natural heart used to be. And then there's also the implanted secondary coil where you could transmit electrical energy and transmit data both ways. What you can't see very well in this chest film is an implanted battery and implanted computer, which help power and run the device. And this was one of our first patients at Jewish Hospital who I spent an extensive amount of time with. It's curious when you spend a lot of time in the operating room, and as well as I'm assuming in anatomy in the cadaver lab, you begin to appreciate how substantial the chest wall is, as well as how elastic it is, and that how intimately connected the heart with the pericardium, with the lungs, and the interior of the chest wall above the diaphragm, and everything below the diaphragm goes. And if you tweak one thing, it's going to be expressed in lots of other ways through the other organs as well. And that comes into play when you go through various levels of acceleration because they're all experiencing it. Just a quick mention, some of my pediatric work, this is a physical simulator of the cardiovascular system that my students and I have developed called CardioKid. We initially developed it to test developing pediatric cardiopulmonary and cardiac assist devices, but we're now converting it into a simulator for training purposes. And if you hook CardioKid up to a patient monitor at the hospital, this is exactly what you would see, ECG and arterial and central venous pressure waveforms, just like you would for a patient. And you can attach a pediatric assist device or put CardioKid on veno-arterial ECMO. So it's been a useful simulation, but all of these different things go into helping me understand the cardiovascular system in other environments. And I have to say, Werner Forsman is one of my role models. He demonstrated that, yes, in fact, you could successfully catheterize the heart with a fluid-filled pressure catheter and measure intracardiac pressure. And he did that by doing it on himself in true physiologic tradition that the principal investigator goes first. And I can say that I've had various catheters in and around my heart during 0G as well, and I'll mention that in a bit. So my heart's always been in space. Fortunately, several years ago, the Hubble Space Telescope actually found it, although the astronomers like to call this the colliding galaxies. But this is one image of looking at the cardiovascular system in spaceflight. But it's a very physical system, pumping, two-chamber pump, conduits, vessels that go all over the place, blood, which is a solution, a physiologic solution. It's a little denser than water. It's relatively incompressible. Now, what do we know about the cardiovascular system from the history of human spaceflight? It's been about 61 years that Yuri Gagarin made the first flight into space of a human, a single orbit flight. As far as I know, he did not have any cardiovascular instrumentation. Less than a year later, when John Glenn became the first American to orbit the Earth, he did have an electrocardiograph, and there was a temperature monitor, and I don't think he had a blood pressure cuff, so still fairly limited. Finally, in Apollo, there was increased numbers of sensors, mostly related to electrocardiograph, temperature, and respiration. And they did also have a blood pressure cuff. So we have some idea of what happens to those in relatively brief space flights. But it wasn't until the first space station, Skylab, in 1973 and 74, that we actually got a lot better idea of changes with the cardiovascular system with extended spaceflight. Because the crews are up there, the longest crew was up there 84 days. They had numerous recordings of electrocardiographs. They could challenge the cardiovascular system with a lower body negative pressure system. They also had a treadmill and an exercise bicycle and other ways that you use to challenge the cardiovascular system. And one of the things that became apparent, particularly in Skylab, with the astronauts staying up for a few months, is the indication that there is a fluid shift that takes place. This happens to be my friend and colleague, Dr. Chiaki Mukai, at the time of her first space flight back in it was late 80s or early 90s. And on the left is her pre-flight image. On the right is her image toward the end of the flight, and you can see that her face has gotten a little bit puffier. And as this was a consistent observation, what was proposed was that in the absence of gravity, which tends to make our blood redistribute it down toward our feet and our legs, that the blood redistributed more headward or cephalad. And one of the ways that was expressed was getting a puffier face. And at the same time, this was actually observations that were made in Skylab. is that the fluid was shifting out of the legs. And actually there was a phenomena that's known as bird legs, where people's thighs and calves actually got a little bit smaller. And my friend and colleague, Bill Thornton, had a study that he published in the Biomedical Results of Skylab showing pre-flight, during flight progressively, that the diameters and the circumferences of the calves and the thighs got smaller. And then as the astronauts returned to 1G and their circulating fluid volume was restored to normal, then they regained pretty much their pre-flight dimensions. So fluid shifting, it depends on the posture. We generally tend to think as upright posture, but you also have to consider what's the effect of supine posture. Also, that you see a little symbol there. It's known as a center of gravity, also it's used to indicate the what's called the orthostatic intolerance point, meaning that below that point, in a gravitational field, hydrostatic pressure increases, and above that point, hydrostatic pressure decreases. What wasn't really considered much until spaceflight was the supine posture with the legs up, which is referred to as the launch position, and which is the position that most every astronaut has launched into space. And what that, when you do these changes in posture, fluid is going to redistribute toward the vascular bed that's more compliant or more receptive to feeling fluid. So oftentimes you'll see a 4-stage fluid shift chart. I actually, because of the work that I've done, prefer these stages, where the first on the very right is the standard image of upright posture with normal volemia. You see a predominantly venous pooling of the circulating fluid volume. And then still, when you're in 1G, when you make the transition to the launch posture, you can see the vascular volume in the legs greatly collapses, and that volume shifts up toward the head. And this is before you even light the rocket motors. So there is a headward shift just by going from the upright posture to the launch posture. And then during the powered ascent, when you're experiencing several Gs, in the shuttle it was up to about 3, in SpaceX you get up to about 6. Saturn V with Apollo, it got up to about 9, and that will probably be very similar with the Space Launch System. So the fluid in the legs gets squeezed even more, and even more fluid goes headward. And then number 4 is early entry into weightlessness, where you get more an equal distribution of the fluid. But even at that, you can see there's still a lot more fluid in the head and above the heart than there is normally in the upright 1G posture. This tends to be interpreted by the fluid volume regulation mechanisms in the body, particularly the atrial stretch receptors that secrete atrial natriuretic peptide, as well as the stretch receptors in the atrium that fill into the posterior pituitary for the secretion of antidiuretic hormone or vasopressin. What that will do then is cause a reduction in circulating fluid volume to a situation where the stretch receptors are no longer stimulated. So the circulating fluid volume is down, but there's still, because of other compensatory mechanisms, there will be sufficient cardiac output delivered by the heart so that the crew members aren't in any metabolic distress. And then with early re-entry into 1G, if you haven't restored or exaggerated or expanded the circulating fluid volume by acute fluid intake prior to re-entry, you'll find out now a situation where there's a relative hypovolemia centrally. And this could lead to orthostatic intolerance if it gets to an extreme. This is the same situation where high performance jet pilots wear G pants, which compress the legs to try to promote venous return during hygiene maneuvers. And then eventually, after several days and weeks of readaptation and sufficient fluid intake, then the circulating fluid volume is restored to the normal 1G upright that we showed 7 images ago. Now, when you look at spaceflight, there are all kinds of challenges that come up related to space health. I just point this out in case you haven't seen this slide. There's plenty of topics for everybody to dig into. I'm just going to focus on some of the things that relate to cardiovascular function. The space shuttle program, which went for 30 years, gave us even more opportunities to under some of the more details of cardiovascular function. And that in particular was on a space shuttle mission in 1985, which was the very first time an echocardiograph had flown in space. So what this did was it gave us the chance to do real-time imaging of the chambers of the heart and not only look at heart rate, but look at critical dimensions in the heart, look at end systolic and diastolic volume, which allows you to calculate the stroke volume. Couple that with a heart rate, you can get the cardiac output. So what you can see here on the left, the blonde-haired woman is Dr. Ray Seddon, one of the first physician astronauts, and she's doing an echocardiograph exam on Jake Garn, who happened to be my senator from Utah at the time. But he and 3 other people had several echocardiograph studies, pre-flight, supine, every day during flight, and then several days post-flight to look at the changes of the heart through the duration of the space flight. And this was the data that was found. And what I'd like to do in particular is point out that the green is the heart rate. You can see that the heart rate pre-flight levels tended to be elevated. The red triangles is the stroke volume index, and the blue diamonds are the left ventricular end diastolic volume index. And what you can see compared to pre-flight supine, the first day of measurements, that the heart was enlarged, the end diastolic volume was larger, the stroke volume was larger, the heart rate was elevated, so the cardiac output was really elevated compared to pre-flight supine. But then by day 2, it was back to normal, and by days 3 to 5 to 7, it was actually about 15 to 20% below normal with the end diastolic volume and the stroke volume, but the heart rate stayed elevated. So when you multiply the heart rate times the stroke volume, the cardiac output is still going to be adequate, and the astronauts aren't at any metabolic deficit as far as oxygen delivery goes. But it raises 2 questions, and it's not unusual for a physiologic response to a stress to see some response that are early on, some responses that are delayed, but there's usually competing forces going on, some that increase the response to the stress and some that have a reduced response to the stress. And so the question is, what is going on that might cause an increased volume early on, but then what would ultimately, when things stabilize several days into the flight, actually a lower stroke volume and a lower end diastolic volume compared to pre-flight supine. And there's several ways that I and the researchers I've been associated with have gone about trying to answer this question. There was also one other piece of perplexing data that came up the first time an astronaut flew with a central venous pressure catheter in on Space Life Science 1 flight. And that was with entry into 0G, the central venous pressure immediately was lower by 4 or 5 millimeters of mercury, which was completely contrary to what was expected. Usually, if with the headward shift of circulating fluid volume to the heart and the heart getting bigger, generally you associated a flexible object getting bigger with the pressure inside being bigger. But I'll I'll get into a discussion a little bit later on of why that may not always be the case, and in this case, certainly not in spaceflight. This is a tracing from the particular astronaut that had the central venous pressure line in. 0 is when the rocket motor is ignited on the shuttle. And so with the increased acceleration, there's increased compression of the chest and the body. Central venous pressure goes up. As the motors throttle back about 2 minutes, the pressure goes back to where it was pre-flight, but then as it picks up again toward 8+ minutes, the central venous pressure goes in. But you can see instantaneously, as soon as the motors kick off, that the pressure is now about 7 to 8 millimeters of mercury lower than it was pre-flight supine. So it's a paradoxical finding. If you think of your Frank-Starling curve, the atrial pressure is on the horizontal axis, the stroke volume or the cardiac output's on the right axis. With increasing pressure, you would expect the stroke volume go up, but in this case, with decreasing pressure inside the heart, the stroke volume was going up. So there's something going on that needs to be explored further to get a better understanding. Now, this is a drawing which you may have seen when you studied respiratory physiology. What it's doing is that it's looking at the relative anatomy and the relative forces that are acting on the heart as it's nestled inside the thoracic cavity, but it's influenced by the action of the chest wall. It's influenced by the action of the diaphragm. It's influenced by a few other things too. If you've ever worked on a whole cadaver in the cadaver lab and spent some time focusing on the chest, you're aware that the chest wall is a very substantial piece of architecture between the muscles and the bones, and that it's very elastic. I mean, if you think about it, the reason why chest compressions for CPR work is because the chest wall is elastic. You apply pressure to it so that you can compress the heart to force out a part of a stroke volume, and then you release it so that the chest recoils back and allows the heart to fill before the next chest compression. Well, what I'm speculating is that there's a balance point for each situation between the pressure inside the thoracic space and the natural elastic recoil tendency of the chest wall, of the muscles and the bones that make up the chest wall. When we're in a gravitational environment, that tends to compress the chest wall to a slightly lower volume than its unloaded rest volume. And then when you go weightless, it relieves that compression, and naturally the elasticity of the chest wall wants to recoil to a slightly larger volume. Now, the thing is, if you subscribe to Boyle's law, in a closed system, the pressure volume product has to work out. So if the volume gets bigger, the pressure inside the volume gets smaller. What that would mean when you enter weightlessness is that the pressure inside the thoracic space actually goes down. And then you have to look at the pressure that actually impacts the cardiac filling. It's not just the pressure inside the heart, it's the pressure outside the heart. And it's actually the difference, which is called the transmural pressure. And because the heart is not a rigid structure that's not influenced by transmural pressure, but rather a flexible structure that is influenced by transmural pressure, you have to look at what's going on. So what I hypothesized was that when you go weightless, you unload the chest wall, which recoils to a slightly larger resting volume. It drops instantaneously the intrathoracic pressure. What that does is that it increases the transmural pressure across the ventricular wall, which tends to draw more blood into the heart during diastole at a lower pressure. The pressure inside the heart will get lower. And then with the next systole, it ejects that stroke volume out. And that's why possibly the overwhelming response the first day of entering weightlessness is that the stroke volume and the end diastolic volume increase paradoxically when the central venous pressure is lower. But I'm going to present now several different experiments that we did, both on the bench and in human test subjects, to acquire data that let you explore those phenomenon a little bit further. So if you wanted to do that, you would want to know the pressure inside the chest. And it's not a smart idea to stick a trocar across the chest wall and then put a pressure sensor in. So intraesophageal pressure is a safe indication of what the intrathoracic pressure is. And then likewise for the intra-abdominal pressure below the diaphragm, if you can get a pressure sensor down there, that would be a reasonable thing to do. So pass a multi-sensor catheter down the esophagus, through the stomach, through the duodenum, and down into the duodenum, possibly even into the ileum, to get an indication of intra-abdominal pressure. Likewise, in the cardiovascular system, you'd want a catheter measuring central venous pressure in the superior vena cava just above the heart. It'd also be interesting to know the peripheral venous pressure by having a pressure catheter down in the saphenous vein. Now, take a step back to some of the artificial heart work that I've done. This is a cross-section of an air-driven artificial heart. It's a pulsatile heart, so like your natural heart, it has systole and diastole. Here on the left, you see diastole. The inflow valve is open, the outflow valve is closed as the blood flows into the heart. And diastole, when the air side of the pumping diaphragm is inflated, increases pressure in the ventricle, the inflow valve closes, blood gets ejected out the outflow, and it just goes back and forth, just like our natural heart does between systole and diastole. Notice in the upper left-hand diagram that the flexing diaphragm isn't completely down to the bottom of the heart chamber. So that gives some reserve with increased filling that could augment stroke volume. And that's what you see in the lower part. So somehow or another in the observations from the echocardiograph with the astronauts, something is augmenting or causing an augmentation of the ventricular filling and then consequently the subsequent stroke volume. So here's a couple of lessons that I learned operating an artificial heart supporting a patient that may give some insights into what's going on with these astronauts with the paradoxical response. So this is Sunny, one of the artificial heart patients that I worked with a few weeks post-op, starting to exercise very slowly on a treadmill to start to regain his strength. One of the things that we knew we could do to increase the cardiac output, because there is no autonomic regulation of an artificial heart like there is our natural heart, was in the drive line that carries the pulse of compressed air up to inflate the pumping diaphragm. If we applied a small vacuum during diastole, it would actually help to draw more blood into the heart, filling the heart so that the next beat or the subsequent beats had an augmented stroke volume. And so what you can see here is the lower curve is a ventricular function curve with no ventricular or no vacuum augmentation of filling. And then the top one is the same device, and the only difference is about 5 millimeters mercury vacuum has been applied during diastole to augment the filling. And you can see that, for example, here at the same pressure, let's say an atrial filling pressure of 5 millimeters of mercury, that you're getting almost 1 liter a minute augmentation. Now, it makes you wonder, in a way, is the elastic recoil of the chest wall, which is dropping the intrathoracic pressure. Is that essentially a vacuum augmentation or a lower pressure augmentation that occurs naturally to increase the transmural pressure across the ventricular myocardium and promote greater filling and consequently greater stroke volume? That certainly is plausible. Now, this is another example. If you think when we go from laying down to standing up, blood starts to pool in our thighs and in our calves. If it pooled greatly, we would eventually get syncope and pass out. On the other hand, when the venous muscle pump kicks in and other regulation, some venous constriction and other things, the circulating volume and return to the heart is adequate. But there's something else that we generally don't think about. And that is when you stand up, your diaphragm descends and pulled down by the abdominal contents. And that has a similar impact as when the chest wall recoils to a larger volume when you release gravity. With an artificial heart patient, of course, their rigid heart is not going to respond to these kind of things. So the compensation is the following. If you look to the left and to the middle, you can see the cardiac output from the left and the right device. And what happens here at point A is the patient is asked to stand up. And when they do that, you can see the cardiac output drops about 1 liter to 1.5 liters. And then they just stay standing and you don't do anything and it stabilizes. At point B, they stay standing, but you increase the vacuum during the diastolic period to augment the filling of the heart. And when you do that, it returns the cardiac output back to the pre-upright position. And I think naturally, although we don't realize it, our bodies do the same thing when the diaphragm descends when we stand up and dropping intrathoracic pressure just a little bit, but it augments the venous return to the heart to maintain the stroke volume and the cardiac output. That could also be an indication. So here we go back to this MRI scan again with the heart intimately coupled with lungs, with the chest wall, with the diaphragm. You can see how changes of pressure around the heart, for either from the chest wall changes or from the dissension of the diaphragm, could influence the transmural pressure of the heart, and therefore the filling and the pressure inside the heart as well. Just to give you an example, this is some anecdotal data of a willing test subject, happens to be me, with a multi-sensor nasogastric pressure catheter in. These are gravitational insensitive pressure sensors. And so starting on the right, I'm laying supine on a tilt table. You can see my intra-abdominal pressure is lower, about 5 or 6 millimeters of mercury. Intra-esophageal pressure is about 5 or 6 as well. But then you begin to tilt, and by the time you get to the point where I'm almost upright, you can see that the intraesophageal pressure, and therefore the intrathoracic pressure, actually goes down, where the intra-abdominal pressure goes up. And that helps to promote venous return 2 ways. The increased abdominal pressure is going to compress the vessels of the splanchnic circulation and squeeze more of that blood up toward the head and toward the heart. And at the same time, as the diaphragm descends, you can see that the pressure inside the thoracic space is going down, which is going to increase the transmural pressure across the ventricular myocardium, drawing more blood in to maintain stroke volume and cardiac output. One other observation, this was a study where we were using a high-speed camera to study the valve action inside the artificial heart. But this particular discussion is not concerned with the valves, but the one thing we noticed, this is during filling up here in the upper right, and then this is the initiation of systole down here. And what we noticed was that the heart always began to fill at the lowest part of where the flexing diaphragm is. And where the thought was, well, it's hemispherical, it would fold randomly. Well, it didn't. It folded in exact same pattern every time. And I speculated that that was because the lowest part has the greatest hydrostatic pressure. And that raises the possibility that hydrostatic pressure, which is gravitationally dependent, would have a contributory factor to the overall filling of the heart, so that if you kept everything else constant, but you went somewhere where gravity was negated, there would be a reduction of the diastolic filling proportional to the average of the hydrostatic pressure. So one other lesson from the same artificial heart patient, what I asked him to do was to go from laying flat on his back to rolling over on his left side. So he's not going the extreme, going from laying down to standing up, but just rolling over on his left side. So there's probably going to be very little fluid shifting, at least from a craniocaudal point of view, that would influence venous return. But again, when you look at what happened, this is on the left-hand side up to point A, that's when the patient was laying supine. And then A is when they rolled over with their left side down. And you can see that instantaneously, the stroke volume and the cardiac output goes up. And then at B, they rolled back laying supine, and it gradually goes back down. What I'm proposing is that the reason why the output goes up is that all of a sudden, when they go from being supine to being left lateral decubitus, that the hydrostatic pressure inside the heart increases. And that serves to augment diastolic filling without making any other change in parameters. So then you see the increase in the stroke volume and the cardiac output. All of these things may contribute to the two-phase response that we saw from the echocardiographic study of astronauts, where their hearts get bigger and have a greater stroke volume, but then eventually have a smaller one. And predicting that the effect of the increased transmural pressure initially is so overwhelming that all you see is the increasing phase. The hydrostatic pressure has gone to zero simultaneously, but its impact is less, so you don't fully appreciate its effect until later, and after there's been a period of adjusting of the circulating fluid volume. So this brought up a project that we had at the University of University of Utah, along with our colleagues at Utah State and at Bellarmine College, which was a small school here in Louisville. And what we proposed was to fly a physical model of the cardiovascular circulation. And again, looking at the anatomy, here you can see that there's a delta H, or a hydrostatic pressure head, between the base and the apex of the heart. And that you see here in the 5 biophysical factors that would influence cardiac filling. One is the atrial pressure, the filling pressure. Second is the inertia as the blood comes into the ventricle. The third is the intrathoracic pressure, which is going to influence the transmural pressure. Fourth is the passive elastic recoil, or the parallel elastic element of the myocytes. And the fifth is this progressively increasing hydrostatic pressure as you go from the base to the apex of the heart. To put a value on this, on an average size heart, this delta H could be about 7 centimeters. And if you look at the hydrostatic pressure equation, when you multiply the 7 centimeters times the gravitational acceleration and the density of blood, you'll come out with a hydrostatic pressure difference of about 5 millimeters of mercury, or an average effect of about 2.5 millimeters of mercury, which sounds small, except when you look at the magnitude of the axis for a ventricular function curve. A couple millimeters mercury difference can actually make a noticeable and a measurable change in the cardiac output. So we have this physical model, which has a pumping ventricle. It's got compliant vessels and chambers. It also has physiologic resistance, so that if you create the model correctly, you'll see an arterial pressure tracing not all that different to what you see in a human being, and the same thing that you'd have a flow tracing. And so we created our, if you will, artificial astronaut who had an artificial heart. It was pumping into an artificial compliance chamber, a systemic vascular resistance, venous compliance chamber, and then to the left atrium, back into the left ventricle, and back out again, this being a closed loop of the systemic circulation. We used the Utah 100 artificial heart, which is one of the artificial hearts that I helped develop. We used the left ventricle. There wasn't enough room to have 2 circulation simulators inside the payload canister that we were provided. So we did just a closed loop with a systemic circulation simulation with the left ventricle. And here we are inside the NASA zero-G airplane. This is the simulator. These are all the members of the project team. And it turns out Barb and I were the 2 people who flew the missions and collected our data. We flew on a KC-135, which is a modified 707 that had been reinforced for this kind of test flight maneuvers. And here you can see the profile. It's similar to flying a 12,000-foot roller coaster in the sky. And as you coast over the top, you get about 15 to 20 seconds of zero-G, depending on the aircraft and the weather conditions and the pilot. So here we have our system again. We're measuring left ventricular pressure in the apex and in the base, aortic pressure, left atrial pressure, aortic outflow. The heart rate is set, so we can calculate the stroke volume, knowing that. And what we did was we collected data on the ground, and we collected data during the parabolic flights. This is the difference in the pressure between the base and the apex of the heart. And as we predicted, given measurement error, there was essentially no hydrostatic pressure head or difference in the pressure. In zero-G, there was about 6 millimeters in 1G, and we typically got between 1.6 and 1.8 G. So you see the elevated pressure above that you'd see in 1G. So there was at least some consistent observation of hydrostatic pressure within the heart changing with acceleration levels. And then these are the ventricular function curves that we could collect from the data at 4 different preload conditions. And as we predicted, the ventricular function curve was shifted to the right about the average effect of the hydrostatic pressure difference that was observed. But this was, very preliminary data. There's not enough time to adjust the peripheral vascular resistance and other things. So we wanted to go to extended measurement of the cardiovascular function. So we then started working toward creating a version that could actually fly in low Earth orbit in sustained reduced gravity. To do that, we had to make the unit much smaller. So here's the first attempt at reducing our system, and this is when our character took on the nickname of Art Hurt. Here you can see Art is now quite small. Whoops. And automated to the point where I could be doing something else while Art was running himself. I just point out, you never know what's going to happen when you fly with NASA. You may recognize Tom Hanks and Kevin Bacon and Gary Sinise. Turns out one of my research flights was the orientation flight for the cast of Apollo 13, which is a movie that was based on the true mission of Apollo 13 and how they had near catastrophe and how they were able to address the challenges and get back safely. If you haven't seen it, I suggest you check it out. It's a very fascinating movie. Anyhow, here's all the details of Art Hart now ready for spaceflight with the instrumented artificial heart, the heart driver, the electronics for the sensors, and the vascular model. Here's Art in his experiment container in the cargo bay of the shuttle. This is STS-95 taking off and landing, and hopefully when we got Art back, he had brought back some data from orbit. And in fact, what you see here is we had limited but useful data collection. So the blue line is the 1G upright, the red line is the microgravity data in orbit, and the green S's are in 1G supine. And so again, consistent with our hypothesis, the ventricular function curve was shifted to the right about the average effect of the hydrostatic pressure difference. And as you would expect, that in supine, you still have a hydrostatic pressure difference, but it's less. So consistent, again, with our hypothesis, the supine data lies in between 1G upright and microgravity. So apparently gravity this suggests that gravity does have a role of contributing to cardiac diastolic function and would contribute to some of the reduced filling and volume after the cardiovascular system is stabilized after a few days in microgravity. Now, the other question is, why would the central venous pressure go down? And we propose that it happens virtually instantaneously, primarily because of the elastic recoil of the chest wall, but also the reduction of compression of the abdominal wall. So what we were able to do was, with willing test subjects, we put a high fidelity acceleration sensitive catheter right here in the superior vena cava, just above the right atrium. We passed a multi-sensor catheter down the esophagus so that there were sensors in the chest and also down here in the duodenum. And we measured arterial pressure with a Phenopress fingertip sensor. We measured ECG. And let's see, also skin perfusion with a laser anemometer. Now, just a little bit more about the biomechanics from the data that was published by Jay Buckey in the article in 1993 that first presented the result where the central venous pressure goes down. If, in trying to reconcile how this could be, if this is the pressure volume loop for 1G, in 0G, clearly there was initially an increased end diastolic volume and stroke volume, but that was also seen down here at a lower pressure. And how could that be? There could magically be some way that the compliance of the myocardium increases, but that's not very likely. The more likely explanation is there's kind of a physical parallel shift during diastole of lowering the pressure. And that would be consistent with the reduction of intrathoracic pressure that I've been talking about. One way we could simulate this was we have a flexible artificial heart on a physical simulation of the circulation, much like the one that we flew on the shuttle, only this is more of a ventricular sac, more like the natural heart. Using ultrasound crystals, we could get instantaneous diameter, which if you calibrate it can be translated into volume. And what we did was we asked the question, if we changed ventricular contractility, if we changed peripheral resistance, if we did a few other things. Oh yeah, and if we reduce the pressure around the ventricular sac during diastole, could we create a similar situation to what we saw and speculate with the astronauts? So here you can see the model. This is the ventricle toward full diastolic filling. This is the coapting quadrants, so the compression like you get with ventricular systole. And consequently, what we found is if this is the normal baseline ventricular pressure volume loop, to get to a pressure volume loop that is consistent with the orbital data, we had to reduce the intrathoracic pressure around the sac by 3 millimeters of mercury. We had to increase the contractility just 5%, and we also had to reduce the systemic vascular resistance. And when we did all those three things, you get the situation where you've got the greater filling and stroke volume at a lower diastolic pressure compared to the 1G situation. So again, there's growing evidence that there is a biomechanical component to the explanation of this change. If we overlay the ventricular pressure curves from the model, you can see that it's a shift of a few millimeters of mercury here during diastole. And then if you overlay the diameter, which would correspond to volume, you can see that compared to the simulation with no vacuum augmentation, that when the vacuum is applied, which was similar to reduction in intrathoracic pressure, you do get the increased end diastolic volume, which would correspond to an increased stroke volume. And that's a blown out version of that. So let's go and gather some data from willing human test subjects where we can measure instantaneously the central venous pressure, peripheral venous pressure, intrathoracic pressure with an intraesophageal position sensor, intra-abdominal pressure with a sensor down in the abdomen. And we're going to start the test subject out in the launch posture, which you see in the upper left, in the supine posture, which is upper right, with 6-degree head down tilt, which is a earth-based model that tries to create the headward shift of fluid that's seen in spaceflight, and then also with upright seated. And here you can see, as I'm hovering over the test subject, that there's this multi-sensor catheter that's nasally introduced and then goes down the esophagus and into the abdomen. And this is an example of the instantaneous tracings that we got. The top is the acceleration. And as you can see, as soon as you go weightless, the central venous pressure goes down several millimeters of mercury, consistent with the orbital observation and with a simulation observation and with what we speculated. The intraesophageal pressure goes down and the intra-abdominal pressure goes down. So there is growing suggestion of this biomechanical effect as well. And in 0G, there really is no posture. So you would speculate that regardless of which of the 4 postural orientations that you started in 0G, that particular physiologic parameter essentially goes to the same place. And you see this very clearly for central venous pressure and within error for intraesophageal pressure, intra-abdominal pressure, and in a couple of cases when we got peripheral venous pressure as well. So, and this is another presentation that shows clearly that the intra-abdominal pressure and the intraesophageal pressure goes down in 0G compared to 1G, which again provides additional supporting evidence for the concept that part of the change, the paradoxical drop in central venous pressure is because of the drop of the intrathoracic pressure due to the recoil of the massive and elastic chest wall. Just mention that there have been larger physical models that we've flown on the airplane and computer models. I'm not going to say anything about that, but I will just mention very briefly, I'm assuming you all have received cardiopulmonary resuscitation training and that you know the value of delivering a good, firm compression to the sternum to try to promote blood flow until the heart can be restarted and the patient resuscitated. That's a little more difficult in 0G because Newton always wins out, and for every action, there's an equal and opposite reaction. So if you gave a chest compression in 0G without any way restraining the victim or the rescuer is just going to go flipping off, and there's no effective chest compression. So we developed a protocol with an instrumented CPR mannequin and also with some instrumented human test subjects where we looked at different ways of delivering chest compressions. We could only do the human test subjects in 1G. we did the instrumented CPR mannequin in 1G and in 0G. Here you can see the instrumentation for the human test subject. ECG, central arterial pressure, central venous pressure, cerebral perfusion with laser Doppler, anemometry of the central arterial vein, or central cerebral artery, as well as NIRS cerebral oximetry. And here you can see the setup in the test lab over at the hospital. The rescuer is doing standard side straddle. If you look carefully underneath, between the rescuer's hands and the test subject sternum, there is a force transducer so that we're measuring instantaneous force delivered. When you do this with a healthy human test subject, you have to do it carefully. We were only doing partial compression so that we didn't risk injury. The other thing is that the compressions were synchronous with systole, because we know of a condition called commotio cordis, where if there's a sudden blow to the heart during diastole, that can trigger arrhythmias or even ventricular fibrillation that can potentially be lethal. So we didn't want to risk that with our test subjects. This is essentially side straddle, but with additional restraining straps like we would use in 0G. And then this is a modified Heimlich, or a backward bear hug, where you have your hands capped together, but not down at the level of the umbilicus, but up at the level of the heart on the sternum to deliver chest compressions this way. This is an example of the data. The top curve is the central arterial pressure made by a high fidelity gravitationally insensitive catheter. That's the red tracing. The purple tracing is central venous pressure. And then here's the intraesophageal and intra-abdominal pressure. The green is the chest force transducer. The white was the cerebral artery transcranial Doppler pressure. And then the yellow is the ECG. And the goal was to deliver a chest compression on every third systole. And as you can see, if you look at the arterial pressure tracing, there is clearly a decided bump in the arterial pressure every third beat when a chest compression is delivered. And you see a corresponding increase in cerebral flow, in intraesophageal, intra-abdominal pressure, and central venous pressure as well. So if we looked at the change in the peak arterial pressure with the 3 different chest compression techniques that we could do on the ground, you could see you could measure differences, but clearly the backward bear hug or the modified Heimlich caused the greatest change that was significant. Likewise, you would see the change in the coronary perfusion pressure with compression versus non-compression situations, which indicates the effectiveness of the chest compression. So then with that background, going to the experiments on the 0G airplane, we have our instrumented CPR mannequin, which we're measuring both depth of compression and force of compression. Again, we're synchronizing it, anticipating a future experiment with human test subjects. And we're doing it in 1G and in 0G. In this case, how you need to restrain the victim. You also need to restrain the rescuer. So here you can see a rescuer with a waist strap that's clasped to the backboard that the victim is on. Here you can see 4-point fixation with an additional pair of straps that goes across the opposite side of the victim. This is vertical CPR, which I suggest you not try in 1G, where the rescuer tries to position their feet directly above themselves so that the ceiling provides a counterforce for when they give a chest compression, so that it will be an effective chest compression. And then the backward bear hug or modified Heimlich. These were the tracings you can see in purple down here, going from about 1.8 Gs down to 0 Gs for a little over 20 seconds. And then the green is the chest force compression, and the red is the compression depth. And you can see we could get pretty substantial compressions, even in 0G. When you look at the 4 different techniques we had 4 rescuers, each doing 4 techniques. You can see there's not a whole lot of difference in the mean chest compression force. So from that point of view, they're all reasonably equivalent approaches. One of the things we noticed was there was measurable mean residual chest compression force, meaning you weren't totally letting up on that chest compression. And the consequence of that is the heart wouldn't be able to fill enough following the previous compression. And the reason why that's happening is the rescuer is reluctant to let go, because then you have to reposition yourself and it interrupts the chest compression process. Likewise, the depth of compression was similar. And if you looked at the data, however, it's like any data presentation, you have to be careful. What we have here, the 4 rescuers, a short old guy, a tall young guy, a short young guy, and a tall old guy. If you look at the box plots on the left, they're the composite of the 4 rescuers for each of the 4 techniques. If you look at the box plots on the right, they're the composite of each rescuer across the 4 techniques. And you can see that the 2 rescuers in the middle had much greater force of compression than the 2 rescuers on the outside. Turns out those are the taller rescuers. The shorter rescuers are the ones on either side. So you have to be, you have to have additional insight as you're analyzing the data. And maybe one of the lessons there is if you're going to have a cardiac arrest on board the space station, make sure your partner is taller rather than shorter to try to maximize the effectiveness of your chest compressions. Well, I'll wrap up by saying this is a very exciting time to look at space exploration. We talk about going back to the moon, possibly even going to Mars, but that's not in the distant future. This is the proposed gateway, which will be kind of like a way station by the moon for lunar landing missions to build a lunar station. In fact, just a couple of weeks ago, the SLS-1 space launch system with the Orion, which is a spacecraft that will normally carry about 4 astronauts, could carry 6 in an emergency, was actually rolled out to Launch Pad 39A for about 6 weeks of testing. And if that goes well, then the scene on the right will become real. The rockets will ignite and hopefully take Orion into orbit. And if that checks out well, Orion is actually going to go out to the moon, past the moon, come back around it, and then eventually come back to Earth over a period of about 30 to 40 days, which will simulate all the different aspects of a lunar spaceflight except for the landing. If that goes well, the expectation is sometime within the next 2 to 3 years, that mission will be repeated, but with 4 astronauts on board. So it'll be very exciting to see how all this transpires, as well as the development of the various lunar landing concepts that are being developed right now. So with that, I'm happy to take any questions you might have. Certainly appreciate your attention. Thanks again for your interest. And hopefully we'll have a chance to visit in person someday.
Thank you so much, George, for that absolutely fascinating walkthrough of the wonderful projects that you've worked on and all those really interesting findings. And thank you so much for explaining the physiology of it so well. And absolutely, we're living in exciting times as far as space exploration goes. So any questions for Professor George before we wrap up? If you'd like to ask a question, please just unmute and ask.
I was just wondering, sorry, that was really fascinating. Thank you so much for that. Do you have any like future sort of projects planned that, you know, expand on any of this stuff further?
Let's put it this way. There are things that I would like to do to expand on this cardiovascular projects. Most of it would involve human test subjects, and most of it would be measurements that it would be very difficult for me to get approved by a human subjects review panel given the ever-growing, more conservative nature of the institutional review boards. That being said, with the collaboration of the right clinicians in the right circumstances, I probably could. What I would really like to do is with the multi-sensor nasogastric pressure catheter to give further documentation of the influence of the interventricular hydrostatic pressure difference and the changes with posture is actually instrument a human test subject with that catheter and put them on a tilt table in the cardiac cath lab and start them out supine, measuring apical and base ventricular pressure, central aortic pressure, central venous pressure, and peripheral venous pressure, and then put them through a tilt where they start out supine and then get up to vertical for several minutes to look at the instantaneous and then the slower second phase of the changes to see if it's still consistent with the concepts that I presented tonight. My guess is right now the IRB would be very reluctant to approve sticking a catheter inside a healthy human test subject. But under the right circumstances and with an experienced interventional cardiac cath lab cardiologist, maybe something like that could be considered. As far as other things, as Rowena mentioned, the project team I'm on, we've been developing surgical capabilities for exploration spaceflight. We've been working on this for about 10 years. So far we've flown 16 zero-G flights and the one suborbital flight, testing out our new techniques and technologies, which is showing promise. It's going to be a long time before it would be perfected. And of course, anything that we do that's inspired by the challenges of spaceflight would also be very applicable to surgical procedures that could be performed on the ground, either in a standard operating room or possibly even in a trauma situation, possibly even a battlefield casualty hospital setting and things like that. We're T-minus 6 weeks and counting toward our next zero-G flight campaign. We'll start the second week of May, where we're going to try out several more techniques. And to expand the experience of it, obviously being the leader of this, I have my particular biases and why we're doing things. So we're actually going to have 4 different people in the role of surgeon trying out some of these technologies to get their assessment of how well it works, what needs to be done to make it easier to use and more applicable to using in zero gravity, as well as get their feedback for use in 1G as well. So that hopefully that will go well, and we'll have lots of information to report by the end of May. Oh, well, one other thing. We try to collaborate with other groups that may have similar interests or may have very, very different interests. And sometimes that's sharing a piece of research equipment. One of the other projects that I didn't mention, which is cardiovascular, is working on long-term preservation of red blood cells. One of my colleagues in the biology department is a desiccation physiologist, and he studied organisms that self-preserve by dehydrating themselves for quite some time. Michael posed the question, well, if these little organisms can do that, why can't red blood cells, given sufficient encouragement? And so he and some of my other colleagues have figured out a process to dehydrate the red blood cells without damaging them. And then they just shelf stable at room temperature in a sealed bag. And when you need them, you reanimate them by injecting sterile saline or sterile water, depending on how they were dehydrated. Massage the bag for about 30 seconds and they're good to go. You hook up your transfusion line and start your transfusion. NASA's concern was in the altered fluid physics of zero-G or reduced gravity, do they rehydrate adequately without clumping? And so we've flown 6 flights inside the glove box that we've created for our surgical experiments with the red blood cell experiment. And then a real extreme example is we've made this really nice glove box that up to 3 people can work in simultaneously. It was originally designed for our suborbital spaceflight of the surgical fluid management system, but there's no reason why it can't be used for parabolic flights and other projects too. So we got approached by the crop production lab down at the Kennedy Space Center during the summer. They're looking at microgreens as a potential candidate crop to fill in some nutritional gaps in the food that astronauts are provided. But one of the questions was, can you efficiently harvest microgreens, meaning sprouts, in zero-G? And they needed a secondary containment chamber like our glove box in order to do that in. So you didn't have plants and sprouts and stuff floating all over the aircraft during the zero-G periods. So we worked together, figured out how we could adapt our glove box that we've been using for surgical experiments and red blood cell experiments to their experiments, where they were going to try lots of different ways of harvesting microgreens. And they flew 3 flights at the end of last year. It looked very promising. The harvesting can be managed using certain techniques. So now they're going to pitch it to the astronaut office down at the Johnson Space Center and see if they want to give it a trial on board the space station and see what the astronauts think, see how the food tastes, so on and so forth, before it could be adapted as a reasonable crop to be grown in the plant facilities that would be used for a lunar station and for a trip to Mars and for a Martian station as well. So sometimes you get involved with collaborations because of a common topic of interest, and sometimes you get involved because you have a unique piece of research equipment that other people can also benefit by. And that's what's happened with the glove box.
Oh, that's really fascinating. And the students are going to take a good look at space food a little later on in the course. So
Good.
Yep. Any more questions for Professor George before we wrap up? No? Okay, well, in that case, if we could all please show our appreciation for such a wonderful and insightful talk, and George, for your generosity coming along today to talk to us and spending so long with us. It's been absolutely wonderful, and we're incredibly grateful. Thank you.
You're welcome. It's been my pleasure to join you virtually, and I look forward to the day when we can in fact do this in person. So good luck to everyone, and we'll see you at some time in the future.